Good evening, all. I am presenting my research on title The Role of Antimicrobial Photodynamic Therapy in Reducing Plaque Accumulation on Healing Abutment and Peri-implant Mucosal Inflammation following implant exposure. Every research starts with a research question, and the research question for my research is that will an additional usage of photodynamic therapy during the healing phase after implant exposure have any benefit on reducing plaque accumulation on healing abutment and peri-implant mucosal inflammation? The background of my study is that the peri-implant mucositis has been doubtlessly attributed to plaque biofilm that is found attached to implant and negotiates the host microbe hemostasis and decides on the mucosal inflammatory lesion that follows. Though a well-occluding implant has a self-cleansing and self-maintaining atmosphere at the peri-implant level, a thorough oral hygiene regimen is to be followed to keep implant mucosal interface free from mucositis. This risk is greater in single-stage implant procedures and during healing, when healing abutment remains exposed to the oral environment, promoting microbial colonization. Conventional methods may alter or damage the implant surface, and there is no universally accepted gold standard treatment currently exists. If photodynamic therapy using lower-level laser techniques can be utilized to create an inflammatory-free mucosa during the healing period of the implant exposure, it would be beneficial in managing the possible peri-implant mucosal inflammation resulting from microbial accumulation around sulcus in case of single-stage implant surgeries. Aim of my study was to assess the antimicrobial effect of photodynamic therapy following implant exposure on plaque accumulation over healing abutment and peri-implant mucosal inflammation. The primary objective of my study is to clinically evaluate the inflammatory status of peri-implant mucosa, and the secondary objective is to microscopically assess the plaque formation on healing abutment following the photodynamic therapy in peri-implant sulcus. The methodology of the study includes 28 implant sites were selected and was randomly divided into two groups, Group A and Group B, with 14 sites each. The Group A is a group where photodynamic therapy is provided, and Group B is the group where no adjunct therapy is done. Following implant exposure using gallium aluminum arsenic diode laser, healing abutment is placed. 7th day following healing abutment placement, Group A is subjected to photodynamic therapy, and in Group B there is no adjunctive therapy done. 14th day following the healing abutment placement, inflammatory assessment was determined by using modified bleeding index and AST level estimation, and the level of plaque formation or the healing abutment is done by using stereomicroscopic evaluation. This shows the clinical photos of my research, where implant exposure is done using laser and healing abutment is placed. Following 7th day following healing abutment placement, the photosensitizer toluidine blue is added, which is followed by photodynamic therapy. 14th day following the therapy, inflammatory status was determined by using modified bleeding index, and AST estimation was carried using an autoanalyzer. And the healing abutment was then removed and was subjected to stereomicroscopic examination. And this image shows the severity of plaque over the healing abutment, ranging from no plaque, mild plaque, moderate plaque to severe plaque. Moving on to the result, based on the inflammatory mediators, the average AST level was found to be higher in Group B, which was not subjected to any adjunctive therapy, and Group B, and the AST level was found to be reduced in Group A, which was subjected to photodynamic therapy, and this shows that a statistically significant difference was found between Group A and Group B. An average modified sulcus bleeding index was determined and shows that Group B shows a higher when compared to Group A, and the difference was statistically significant. Moving on to the severity of the plaque formation, out of 14 healing abutments, 11 of the healing abutments in the Group B shows high severe plaque formation compared to Group A, which shows that the plaque harboring is more in those healing abutment which was not subjected to any photodynamic therapy. Summarizing the result, the mean AST level in Group A was found to be 522.8 microliter, and Group B was found to be 1,340. The mean modified sulcus bleeding score in Group A was found to be 1.35, and Group B was found to be 2.29. The mean score of stereomicroscopic evaluation of plaque in Group A was found to be 1.93, and Group B was found to be 2.78. Interpreting the result shows that the clinical, biochemical, and stereomicroscopic analysis revealed a consistent increase in inflammation and plaque accumulation among Group B, which shows that the clinical relevance of using photodynamic therapy in reducing peri-implant mucosal inflammation in case of implant site loaded with healing abutment. Moving on to the discussion, as obtaining the result, The inflammatory markers such as the AST level and the modified bleeding index was found to be reduced in those group which was subjected to photodynamic therapy, and the severity of plaque was reduced in those group which was subjected to photodynamic therapy when compared to the control group. And these are the list of certain previous studies which supported my study. And this is the gist of the discussion and the literature supporting the findings. Based on the result obtained, I have concluded that in cases where prolonged usage of healing abutment is indicated, photodynamic therapy would be an efficient tool in reducing peri-implant mucosal inflammation, especially in cases of single-stage implant surgery, where healing abutment is left in situ for several months. Thus, based on the result obtained, I have derived my answer to the research question that the photodynamic therapy used as an adjuvant to the ongoing healing process of peri-implant mucosa in 1 or 2 stage implant surgery do have a positive effect on reducing plaque accumulation at the transgingival element area and exhibited an anti-inflammatory effect assessed using clinical and biochemical techniques. Clinical implication of the research question includes, as inferred in the present study, photodynamic therapy do possess an ability to reduce plaque accumulation in the 2-stage implant surgery. It has been proven that this therapy do reduce the epithelialization time of peri-implant soft tissue surrounding the transgingival element area, thus favoring the faster healing and formation of mucosal sulcus. These are the...
Good evening. My paper presentation is titled as the assessment of peri-implant bone formation and soft tissue changes in immediate implants of varying horizontal defect dimension using connective tissue graft as a barrier membrane. The study was initiated upon the research question, will the usage of connective tissue as biological barrier over immediate implant has any additional benefit in peri-implant mucosal integrity? Coming to the background, peri-implant soft tissue management starts at the time of tooth extraction, not following implant placement. A gap can occur on any aspect of immediately placed implant due to the discrepancy in size and form between the extraction socket and implant. This gap between the implant periphery and surrounding bone is called the gap or jumping distance, and the gap consists of two dimensions: horizontal defect width and vertical defect height. The maintenance and augmentation of soft tissue is most challenging in immediate implant placement, and the major challenges are insufficient socket coverage leading to implant exposure, reduced attached mucosa ridge, inadequate soft tissue overlying the implant. One of the most predictable techniques to overcome these complications is the usage of connective tissue graft as a biological barrier in immediate implant. Considering the clinical risks involved and patient morbidity, connective tissue grafting in immediate implant should ensure significant beneficial effects in peri-implant mucosal integrity. Here arises a definite need for such a study mentioned in the title. The connective tissue grafting procedure involves moderate patient discomfort and extra-operator skill. An original study was conducted to assess the true benefit of such a procedure commonly used in immediate implant cases. Coming to the limitations reviewed in the key articles, the comparison in gain in attached mucosal width and mucosal biotype in immediate implants covered with and without connective tissue graft was not assessed. The horizontal dimensional defects of more than 2 mm managed without bone grafts were assessed in very few studies only, and no studies considered
1 minute,
such an
doctor.
assessment following usage
1
of
minute.
connective
Please
tissue.
move your slides because we can only see your first slide. So as you are changing, please go down and show us which slide you are talking about.
Ma'am, now I'm talking about the limitations reviewed in the key articles.
But we can see your title slide, I think. Am I right, Dr. Krishnan?
Yeah, I was wondering, but
Yes, ma'am.
I just...
Yeah, so please use your down arrow maybe and go
Ma'am,
down.
Doctor, can you see the 63% at the right bottom? 63. Just beside it, there is small button. Can you click it? Slideshow. In the lower bottom, see 63 is written.
Okay.
Okay.
It's not getting full screen. Okay, so as you're changing, like as you're talking, please make sure the slide is also what you can see. Okay. Now you're talking about limitations, right? Okay, go ahead. You're on mute. Please unmute yourself.
Doctor, can you please unmute and continue your presentation?
Ma'am, is it audible now?
Yes, you are audible.
The limitations in the key articles reviewed were the comparison in gain in attached mucosal width and mucosal biotype in immediate implants covered with and without connective tissue graft was not assessed. Horizontal dimensional effects of more than 2 mm managed without bone grafts were assessed in very few studies, and no studies considered such an assessment following usage of connective tissue as a barrier membrane. Reviewing the literature, several lacunae and limitations were found, and in order to overcome it, an original study with following rationale was formulated, that is to assess and compare the gain in attached mucosal width, mucosal biotype, and jumping distance in immediate implants covered with and without connective tissue graft. The aim of the study was the assessment of efficacy of using connective tissue graft as a barrier membrane in immediate implants with horizontal defect dimensions. The aim was extended into the following objectives: to compare the zone of attached mucosa and mucosal biotype overlying immediate implants covered with connective tissue graft and conventional flap adaptation; to assess the bone fill achieved in cases with varying levels of horizontal defect dimensions around immediate implants augmented with connective tissue graft as barrier membrane. To fulfill the two objectives, a methodology was formulated with the study design of prospective cohort study, and the sample size was calculated to be 44. The samples complying with the following inclusion criteria were selected: patients systemically fit to undergo standard implant surgical procedure, patients requiring multiple extraction with at least 2 sites ideal for immediate implant placement, healthy subjects with age group beyond the age of 18, and for patients voluntarily agreeing to the study protocol and instructions recruited. The methodology can be summarized into the following flow diagram: 44 multiple extraction sites selected from patients with at least 2 extraction sites indicated for immediate implant, and it was grouped into A and B, with Group A having cases planned for immediate implant with conventional flap adaptation, and Group B with cases planned for immediate implant with connective tissue graft coverage. And the teeth was extracted with high precision and with every atraumatic means. Immediate implants were placed, and further groups A and B were subdivided into A1, A2, B1, and B2, where A1 and B1 had horizontal defect dimension measuring 0 to 2 mm, and A2 and B2 had horizontal defect dimension measuring 2.1 to 4 mm. In A1 and A2, flap closure was done with conventional flap adaptation, and group A2, where the defect dimension was more than 2.1 mm, the bone grafts were placed. In group B1 and B2, the flap was closed with connective tissue graft coverage. After a 6 months follow-up, the horizontal defect dimensions was measured through CBCT for the bone loss, attached mucosal width, thickness, and thickness of the mucosa overlying the implant was measured. Percentage of mucosal coverage was also assessed. And intercomparison of groups A1, A2, B1, and B2 were done. And these are the photographs of the standard protocol followed: the preoperative photograph, extraction site, immediate implant placement, measurement of horizontal defect dimensions, suture placement at implant site, assessment of mucosal coverage, mucosal biotype, mucosal width after 6 months, assessment of peri-implant bone formation for the bone loss using CBCT. In Group B, connective tissue procurement is done. Placement of bone graft, placement of connective tissue graft, suture placement at donor site of connective tissue, suture placement at implant site, again assessment of mucosal coverage, mucosal width, and assessment of peri-implant bone formation. Coming to the results, intercomparison of the mean attached mucosal width was done among the groups A1, A2, B1, and B2, and statistically significant results were obtained. Intercomparison of mean mucosal coverage was also done, but statistically significant results were not obtained. Intercomparison of mean mucosal biotype was also done, but statistically significant results were not obtained. But in the intercomparison of peri-implant bone fill achieved, statistically significant results were obtained. Coming to discussion, a study conducted by George et al. In 2015 concluded that the subepithelial connective tissue graft over immediate implant circuit provided better results. This was contradictory to present study, where better results were seen with conventional flap adaptation with horizontal defect dimension more than 2 mm. The present study concluded that the zone of attached mucosa showed better results, and peri-implant bone formation was seen more among conventional flap adaptation group with large horizontal defects. Both mucosal coverage and mucosal biotype was achieved in most cases, and the present study could not exhibit any added benefit of connective tissue graft coverage over conventional flap adaptation. The limitation of the study, though the large sample size was selected, but better sample size would have been made the study more reliable and with least errors. Standardizing the samples were a mere impossible task considering the clinical condition, especially when considering the reasons for extracting the tooth and the amount of bone available for implant placement. Answer to the research question: the present study could not establish expected outcome that usage of connective tissue graft as a barrier membrane do have an additional benefit in peri-implant soft tissue integrity.
Good evening, everyone. I am going to present my paper on the topic Evaluation of Stress around Conventional and Short Implants Placed in Normal, Augmented, and Deficient Mandibular Ridge using Finite Element Analysis. Coming to the introduction, dental implants has been considered as one of the predictable treatment option for replacing missing teeth, and there are various factors determining the success of dental implants. Among them, one of the important factor determining the long-term success is implant biomechanics. Here, we'll be seeing about conventional and short implant placed in normal, augmented, and deficient ridge conditions. Before moving on, I would like to tell few words on what is finite element analysis. Finite element analysis is the use of calculations, models, and simulations to predict and understand how an object might behave under various physical conditions. Finite element analysis uses finite element method, a numerical technique that cuts the structure of an object into several elements and reconnects them at a point called nodes. So the aim of the study was to evaluate and compare stress distribution around conventional and short implants placed in normal, augmented, and deficient posterior mandibular ridge using three-dimensional finite element analysis. Objective was to compare and analyze stress distribution around standard and short implants on application of masticatory force to compare and analyze stress distribution among normal, augmented, and deficient ridge. So coming to the methodology, CBCT data of posterior mandible was used to develop a model replicating a clinical scenario of missing mandibular second premolar and first molar. The models were constructed using various softwares to assign the characteristics of D3 bone. A CBCT scan of edentulous mandible was used to develop the model. The DICOM file of CBCT was converted into STL file using Mimic software. This STL file was used to develop a three-dimensional model using SolidBug 2014, and three models were prepared. First model serves as a control group with a ridge height of 10 mm. Two standard implants of measurement 4 into 8 mm were placed in the first model, and in the second model it serves as an augmented group with a bone height of 6 mm and 4 mm of augmented ridge. Two standard implants of measurement 4 into 8 mm were placed, and third group serves as a deficient ridge with a residual bone height of 6 mm and short implant of 4 into 5 mm were placed in these three models. In these three models help us to analyze the biomechanical behavior of implant bone and the surrounding structures. And after preparing the model, occlusal loads were applied based on studies by Major et al. Three loads were applied. First is a 35 Newton vertical load, second is 10 Newton horizontal load, and third is 70 Newton oblique load. After application of the load, analysis was performed using ANSYS Workbench 18.1 software, and maximum von Mises and principal stress of the three models were calculated, and von Mises stress and principal stress of cortical bone, cancellous bone, and implant structures were also analyzed, and the mechanical properties of each and every material used in this model were obtained from previous researchers. Uh, in this study, a descriptive statistic analysis was used to interpret the data. IBM SPSS statistic version 25.0 software was used. In the results, we can see that in all the three models, the highest stress was concentrated in the crestal cortical bone, and among the three models, the highest stress was concentrated in the crestal cortical bone of model 3, which indicates a short implant placed in deficient ridge. So this is a pictorial representation in which we can observe a higher stress observed in the crestal cortical bone of all three models, and also higher stress was observed in crown structures of all three models. And on application of load, the stress transferred from implant to bone was higher in model 3 compared to the other three models, indicating a least favorable biomechanical behavior. In the discussion, I would like to highlight that the higher stress observed in model 3 was in accordance with findings of two other authors who also reported an increased crestal bone stress in shorter implants placed in compromised bone. And before concluding, I would like to tell a few limitations of this study. In this study, all the models were assumed to be homogeneous, isotropic, and linearly elastic, which does not fully replicate a complex biological property of human bone. And the study was assumed to be completely osseointegrated, which does not represent early healing condition, and the study is based on computer simulation and requires validation through long-term studies. And finally, I would like to conclude by saying that finite element analysis is an effective tool for evaluating stress in different conditions, and standard implants placed in adequate and augmented ridge shows more favorable stress distribution compared to short implants placed in deficient ridge, which requires a careful case selection. These are my 3 articles, and I would like to thank you for giving me this opportunity.
Now,
Good evening, everyone. I'm presenting a paper on comparative assessment of autogenous bone graft and allograft as a bone filler in immediate implant sites, a prospective cohort study. Coming to the background, autogenous bone grafts are known to be the gold standard graft material in guided bone regenerative techniques, but requirement of an additional site for its procurement and limited availability makes its usage minimal. The entire study was initiated upon the research question, can autogenous bone graft procured from osteotomy sites be used as a substitute to the conventional allograft material as a bone filler in immediate implant cases? Here arises a definite need for such a study mentioned in the title. A study needs to be conducted to evaluate the efficacy of autogenous bone graft material used for the purpose of filling the jumping distance in comparison with the allograft. Such a study would give more finer insight in the usage of autogenous bone graft material in guided bone regeneration techniques. Rationale for the study: to investigate the quantity of bone fill achieved by autogenous bone graft as a substitute to the decalcified freeze-dried bone allograft. The two aforesaid materials should also be compared radiographically by means of CBCT to determine the bone density of newly formed bone. Aim was fixed for the study, which was comparative assessment of newly formed bone at immediate implant site with the usage of autogenous bone graft and allograft materials. Aim was extended to the following objectives: to quantify and compare the amount of bone fill achieved with the usage of autogenous bone graft and allograft at immediate implant sites, to assess and compare the density of newly formed bone at the graft site with the usage of autogenous bone graft and allograft. And methodology was formulated, and the study design was of prospective cohort study, and sample size was calculated using G-Power software. Total sample size of the study was fixed to be 12. And the inclusion site criteria is as follows. And the methodology can be summarized into the following flow diagram. Sample patients complying with the inclusion criteria were included in the study. Total sample size was fixed to be 12 immediate implant sites. And Group A and Group B included 6 patients each. And Group A patients with need for immediate implant placement with horizontal defects being filled with the autogenous bone graft. And Group B, the allograft was used for filling the defects. And extraction were performed with utmost care with the placement of immediate implants in the sockets. And the horizontal defect dimension was measured from the outer surface of the implant to the inner socket wall at the area with the maximum defect using Williams periodontal probe and recorded. The values obtained were tabulated for future comparison. Only the sites with greater than 2 millimeters of jumping distance were only considered for grafting. In Group A, the defects were filled using the bone graft collected, autogenous bone graft, and Group B, allograft was used to fill the defects. The socket and implant platform was secured using advanced flap from both sides covering the socket mouth completely without any tension, and review was done after 6 months. The CBCT examination was performed of the same site considered initially to assess a percentage bone fill and bone density at the study site, and values were measured and tabulated from the preoperative sites considered. The density of bone formed in the earlier defect areas were initially evaluated in grayscale values, which were converted to equivalent Hounsfield units and recorded. The data were tabulated and compared for the percentage of bone fill achieved at the graft sites and its density to decide the superior graft material. And these are the photographs of the standard protocol followed. Extractions were carried out in both the groups, in both Group A and Group B. In Group A, the autogenous bone graft particles collected from the drills were soaked in saline, and these are the implant in situ photographs. Horizontal defect dimensions being measured. The horizontal defects were compacted with the autogenous bone graft material. Sutures placed immediate postoperative radiographs of the implants, and the 6 months postoperative CBCTs showing the complete bone fill. Coming to the group B, the implant in situ photographs, the graphs, the defect sites being measured from the 2 different points. The defect site were filled with the allograft material, sutures placed, an immediate postoperative implant in situ radiograph, and 6 months postoperative CBCTs, again showing the complete bone fill in allograft bone group. Coming to the results, this is a graph showing the intercomparison of the mean percentage bone fill between group A and B. And group A, the autogenous bone graft group, showed higher bone fill. And the bone density was also found to be higher in the autogenous bone graft group. The present study concluded that the autogenous bone graft material collected used to pack the defects has shown to achieve better bone fill compared to the allograft material. The difference in the density of the autogenous bone graft was superior to the statistical significance. This bone graft material can be effectively used in restoring the jumping distance. Limitations of the study has been limited to minimum sample size owing to its limited study period. The pre and post-operational comparison is done between clinical and radiographical means that could not be made uniform because of ethical reasons. The standardization of the defects managed by different techniques were not possible since no two different sites were alike in any aspects. Allografts are not the commonest graft material used in implant dentistry. So comparison of the autogenous bone graft with other possible graft materials would have made the study more relevant. Answer to the research question: the present study has analyzed the efficacy of the autogenous bone graft in comparison with the allograft material in achieving a complete bone fill and horizontal bone defects associated with the immediate implant cases, and also the density of the newly formed bone. In both the conditions, the autogenous bone graft material was shown to be superior substitute to the conventional allograft material. Clinical conclusion to the research conclusion, that is, autogenous bone graft harvested from the osteotomy site is the cheapest and most effective way of procuring any bone graft material. The study has proven this material to have a superior outcome in managing the jumping distance in immediate implant cases. These are my references.
Good evening, judges. Today, my paper presentation is on assessment of hard tissue dimension changes in the socket walls following socket preservation technique using connective tissue graft as a barrier membrane in immediate implants. Here arises a research question: will the usage of connective tissue graft as a barrier membrane in immediate implant placement have any significant role in preserving the residual ridge? So coming to background, after tooth extraction, the alveolar ridge undergoes evident reduction both vertically and horizontally. In the horizontal plane, the majority of the bone loss occurs in the buccal aspect in the upper jaw as well as in the lower jaw, resulting in the reduction along in the palatal aspect in length as well as height. The helium complex in the mandible, with the bone loss occurring from the labial aspect anteriorly and lingual aspect posteriorly, thus matching the regions where the cortex is inherently porous and where the rate of bone turnover is higher. So immediate placement of implants in the fret extraction socket, increasingly popular treatment option nowadays. And if it is flapless, then it could be traumatic and might help to preserve the architecture of the interdental tissues. Immediate implant placement can be performed in a variety of procedures, either with or without flap elevation or with or without additional bone regeneration procedures. So immediate implants with connective tissue is required in most immediate implant cases to establish a facial bone and soft tissue of sufficient thickness to minimize the gingival recession and volumes of peri-implant tissue. So here arises a definite need for this study. Connective tissue graft offers the best possible coverage technique used in the immediate implants, but the patient mobility factors and operator skill in performing such a procedure makes it least favorites among the clinician. A critical evaluation of the cases utilizing connective tissue graft membrane in immediate implant cases are to be studied to have a benefit over other conventional technique, and if found to be useful, it should be routinely used in the indicated cases. So based on the various review articles we reviewed, the three-dimensional radiographic imaging CBCT-like means were lacking in the review articles we had reviewed. So a rationale of the original study has put forward for comparing the major technique used to achieve a socket preservation during immediate implant procedure to be taken up. Such a study should also take into account the use of connective tissue graft and its application as a barrier membrane in immediate implants and its long-term follow-up study of its soft tissue and hard tissue changes. So thus, an aim of the study was formulated to assess the efficiency of the connective tissue graft as a biological barrier in preserving the socket wall in immediate implant placements. It was extended to the following objective. to compare and assess the dimensional changes of the extraction sockets prior to and following extraction at the end of 6 months, and also to assess the dimensional changes of the extraction sockets preserved with immediate implants with or without the usage of connective tissue as a barrier membrane using CBCT. So the methodology was it was a prospective cohort study with a sample size of 42 and over a period of 18 months. These were the inclusion criteria we had. And the methodology in detail: 42 multiple extraction site segment subjects with at least 2 immediate implant sites and 1 non-implant sites was taken, which was grouped into 3 groups, A, B, and C, with sample size 14 each. Group A was site for non-implant placement, Group B with immediate implant placement, and Group C with immediate implant placement with connective tissue graft. Then CBCT estimation of the buccolingual width measured between the outer cortical bone of the sites were recorded. The traumatic extraction of the teeth was done, and again, after 6 months, this again we have. Okay, then after that, so Group A was left with sutures, and Group B was left with the implants and direct flap closure, and Group C was with immediate implant and connective tissue graft. Then review was done after 6 months using same CBCT, and in the comparison of the groups to assess the socket wall width was made. So this was the clinical photographs and the CBCT recorded before the extraction, and this is the extracted tooth and site. This was the CBCT after 6 months for Group A, and this was for Group B, pre-CBCT and clinical photographs, extracted sites, and one site was placed with immediate implants, and this was the CBCT, which is taken after 6 months. And this is Group C with immediate implant placement, and connective tissue graft was placed over the immediate implant because if it was a flapless technique, and both the area was sutured. This was the post-CBCT afterwards. So coming to result, in the comparison of average total bone dimension reduction in Group A, B, C was evaluated, and more bone loss was seen in the Group A. So descriptive statistics of the pre and post-operative buccolingual levels in Group A, B, C was taken, which was taken at the level crest below 3 mm, 5 mm, 7 mm, and all this shows there was a less reduction in the Group C, which is having issue with immediate implant with connective tissue. Again, in the group comparison of mean difference of percentage of bone reduction among Group A, B, C at the level 0 means at the crest alone. Here also Group C shows less bone reduction compared with A and B group. So coming to discussion, the dimensional changes of the extraction sockets preserved with immediate implants with and without the usage of connective tissue as a barrier membrane was assessed using mean difference between pre and post-operative value was assessed for each groups. And the p-value was found to be 0.0001, which shows a statistical significant difference between the groups and shows a C group have a more less bone reduction compared with A and B. Crystal bone reduction was lesser in Group C compared with A and B. This shows the importance of connective tissue graft as barrier membrane, which many authors describe as a gold standard. Coming to conclusion, maintaining the buccolingual diameter of a socket is a challenging process after extraction. So out of 3 techniques proposed, each of them had its own merits and demerits. Hence, a comparative study to assess the best technique among them was necessary. So Group C utilized connective tissue graft as a barrier membrane, which exhibits a little benefit over the other 2 groups. Limitations of the study was a larger sample size could have more accurate assessment. Standardization of the socket selected for the study could not achieve due to difficulty in the similar sample sets, but somehow difference between sites was so insignificant. Answer to the research question was: connective tissue graft offers a free and relaxed coverage of flap over the area that acts as a bridge between the flaps that could possibly relieve the tension over the existing socket wall and also favor in augmenting the tissue architecture. Application of research conclusion: the selection of technique to meet the socket preservation of an extraction socket along with immediate implant platform is left open to operators' skill and operation sites, which should consider least traumatic and most feasible technique among these 2. So the usage of connective tissue graft as a biological membrane in immediate implant cases with wide horizontal bone defect is highly justified and should be considered in such clinical conditions. These are my references. Thank you.
Very good evening to one and all of you present here. Respected judges and dear colleagues, I'm here to present a paper on the effect of socket preservation technique on bone healing at sites planned for implant placement, a cohort study. Every research begins with a question we ask ourselves. My research began with this question: can socket preservation procedures, an extraction socket, enhance healing process, and aid in early placement of implants. Coming to the background, placement of implants require adequate quality and quantity of available bone. It is therefore essential to maintain and preserve the sockets in patients interested in replacement of teeth with implants. Platelet-rich fibrin is preferred for socket preservation because of its autologous nature and rich supply of growth factors. Coming to the need of the study, a study was found essential to compare the natural healing versus the induced healing in alveolar sockets, as it would give proper guidelines on how to approach such implant sites. The study would also give an insight into the fact whether such preservation techniques enhance the healing period, facilitating earlier implant placement. Several articles were reviewed and among them a few articles were selected. I selected around 6 key articles, but however, there are limitations for these key articles. The literature lacks studies that compare the amount of bone fill achieved among the various socket preservation techniques. The bone density of the achieved bone following socket preservation was also not assessed. Coming to the rationale of the study, an original study had to be undertaken with the rationale of comparing the 3 commonly used socket preservation techniques to identify the best technique that would favor early implant placement in extraction sites. So this rationale was extended to this aim, that is comparative assessment of extraction socket healing following usage of preservation technique using PRF alone and with demineralized bone matrix covered with PRF membrane. This aim was extended to the following objectives. 1, to compare and assess the quantity of bone fill achieved following normal healing and with preservation techniques at the end of 3rd month. 2, to compare and assess the density of newly formed bone in the extraction socket with and without preservation technique using PRF alone and along with demineralized bone matrix at the end of 3rd month. The methodology was designed to be a cohort study, and the period of study was decided to be 12 months. And the sample size was calculated to be 6 in each group, a total of 18 samples. These were my inclusion criteria. And the methodology can be formulated in this flow diagram. 18 sample sites were randomly assigned into 3 groups. Group A consisted of those sockets planned for normal healing, 6 sites. Group B consisted of sockets preserved with PRF and bone graft, 6 sites. And Group C, sockets preserved with PRF alone. So careful extraction of the teeth was followed by socket preservation technique as per the group requirements. Assessment of bone fill achieved was assessed by RVG at day 0, 3rd month, and 3rd month. Bone density assessed was at 3rd month using DentaScan, and intercomparison of the observed data of the 3 different groups to assess the technique to achieve the highest bone fill was assessed after 3 months. The assessment of the bone fill was done using RVG. And these are the photographs of the protocols followed in all the 3 groups. At day 0, the depth of the socket was measured from a reference line connecting 2 fixed points on the occlusal surface of 2 nearby teeth. And the same measurement was repeated at the end of 3rd month from the same reference line to the bone fill achieved, and it was measured in millimeter scale. The assessment of the bone density using DentaScan was done using a circular histogram. Both the average bone density and the most densified area was also identified, and the measurements were tabulated in Hounsfield units. This was the methodology followed. These are photographs of those samples belonging to Group A where no preservation was done. We can see the radiographs taken at day 0 and the 3rd month, as well as the DentaScan assessment at the 3rd month. These are a series of photographs belonging to Group B where sockets were preserved using both PRF and bone graft. That is, demineralized bone matrix was used, and we can see the radiographs taken at the time of extraction, 3rd month, and the DentaScan assessment at 3rd month. And these are those sockets which were preserved with PRF alone, that is belonging to Group C, and the same protocol was followed here too. Coming to the result, intergroup comparison of mean bone fill achieved at the end of 3rd month showed that the Group C was achieved highest bone fill compared to Group A and B. And the intergroup comparison of the maximum densified area after 3 months showed that Group A, that is those sockets which were left to heal normally, had the highest densified area. And the intergroup comparison of the average bone density at the end of 3rd month showed a slightly higher advantage in Group B, which had a higher average bone density compared to Group A and C. Coming to the discussion, assessing the first objective, all techniques showed good bone fill at the end of 3 months' time without any statistically significant difference, indicating that there was no direct effect in socket preservation procedure. Regarding the bone density of newly formed bone assessed using DentaScan, Group A, without any additional preservation technique, exhibited maximum bone density, while the average bone density was found to be almost equal among all the groups. Coming to the conclusion, none of the groups under the study could exhibit a supremacy over the other in terms of bone fill achieved and also its density within the study period of 3 months. So my limitations were, the major limitations was its limited sample size and the shorter assessment period. Variables like age, gender, and site were not standardized, and RVG could have been substituted with CBCT. Socket closure achieved in each case was different and could affect the outcome of healing. The reference point used in assessing the bone fill using RVG could have been made more accurate considering its practical difficulty. The answer to my research question was no difference in vertical bone fill and density of formed bone in the extraction socket was achieved. However, the review of literature strongly support the use of socket preservation technique with regards to other dimensions of new bone formation. So the clinical application of my research conclusion is socket augmentation technique fails to exhibit any changes in the quantity or density of the formed bone compared to the normal healing. Hence, such a technique can be limited to cases which is of its absolute necessity, like conditions that need perfect three-dimensional bone fill. These were my major references. Thank you.
Title of my presentation is Correlation of Width of Attached Mucosa in Peri-implant Tissue Response in Implant Supporter Overdenture using Ball Abutment Connectors. The whole study was initiated with a research question. Does the width of attached mucosa has significant role in peri-implant mucosal health in ball abutment supported overdentures? Background for the study was ball abutment supported overdentures are widely accepted in cases with rehabilitation owing to its less cost and minimal stress transfer. Adequate width of attached mucosa is optimal for peri-implant mucosal health. The present study has undertaken a critical evaluation of mucosal health of such overdentures with ball abutment placement, minimal width of attached mucosa. Overdentures are generally planned in situations of reduced ridge dimension, which is naturally situations with least attached mucosa. A critical evaluation of peri-implant mucosal health following the placement of ball abutment at varying width of attached mucosa would be a decisive factor in planning such overdentures with limited attached mucosal width. Here arises a definite need for the study and mentioned in the title. The overdentures are generally planned in situations of reduced ridge dimension, which is naturally situations with least attached mucosa. The critical evaluation of peri-implant mucosal health following the placement of ball abutment at varying widths of attached mucosa would be a decisive factor in planning such overdentures with limited attached mucosal width. Rationale of the study. An original study need to be conducted with the rationale of assessing the peri-implant mucosal health in overdentures supported by ball abutments with varying width of attached mucosa. The aim of the study was the assessment of peri-implant tissue response with varying width of attached mucosa in implant support overdenture using ball abutment connectors. The objectives of the study to compare and assess the peri-implant soft tissue response with varying width of attached mucosa in implant support overdentures using ball abutment connectors following its loading. To compare and assess the peri-implant bone level at sample sites using CBCT. Materials and methods. The study design is a longitudinal study and the study size is 24 sites indicated for single stage implant surgery for overdentures. Period of study is 1.5 years. These are the inclusion criteria. The flow diagram of methodology, 24 sites indicated for single stage implant surgery for overdentures selected. Implant placed at crustal level with at least 1 millimeter of bone on both sides. Radiographic evaluation to confirm the placement of implant at crustal level. 4 weeks after initial placement, the whole sample is grouped into 3. Group A attached mucosal width up to or equal to 1 millimeter. Group B attached mucosal width greater than 1 millimeter up to 2 millimeter. Group C attached mucosal width greater than 2 millimeter and up to 3 millimeter. Keratinized mucosal width at same sites were examined and recorded for the future comparison. The overdenture with ball abutment connectors placed as per the loading protocol. 6 months follow-up after loading. The clinical evaluation and radiographic evaluation were done. Under clinical evaluation, characterized mucosal width, attached mucosal width, modified plaque index, modified bleeding index, and mucosal recession were assessed. Intergroup and intragroup comparisons were done at the end of the study using paired t-test and ANOVA test. These are the photographs taken. The probing pocket depth measuring taken using plastic periodontal probe and keratinous mucosal width taken using Williams periodontal probe. Attached mucosal width is measured from keratinous mucosal width minus probing pocket depth. This is a post-operative clinical assessment photographs. Attached mucosal width, modified plaque index score, modified sulcus bleeding index, and mucosal recession. These are the post-operative radiographic assessment done. The intergroup comparison of modified plaque index, sulcus bleeding index, mucosal recession, and bone loss among Group A, Group B, and Group C. The result revealed that when attached mucosal width is reduced, there was an increase in modified plaque index, sulcus bleeding index score, and vice versa. The mucosal recession values was found to be more in sites with least attached mucosa. Moving on to the discussion, the conclusion of studies conducted by Tabrizi et al. In 2024 and Todisi et al. In 2019 were found compliant with the present study conclusion, though the objectives and parameters differed with the study. Moving on to the conclusion, peri-implant health has profound relationship with its overlying mucosa, especially in conditions like overdentures, as its treatment is often done in conditions with least amount of residual ridge. Moving on to the limitation of the study, the sample considered possesses a minimum range of difference between them. Wider range difference would have made it more authentic. Increase in sample size and its standardization technique would have been a definite choice if possible. Measurement of the width of keratinous mucosa at various conditions is not easily accessible with parameters used in the study. The functional low transfer implant placed at different sites within the assessed group could not be standardized. In most samples considered, the residual bone on facial aspect the bare minimum, and this could have a negative assessment in imaging measurement accuracies. Moving on to the answer to the research question, wider attached mucosal zone exhibited better peri-implant health following the loading of overdentures supported by ball abutments. Clinical application. As it is evident that overdentures are choices of least residual rich areas which would be left with least attached mucosa, it is desirable to utilize overdenture as it significantly contribute to residual rich resorption and improve peri-implant mucosal health. These are the references. Thank you.
Good evening. Today my topic is on comparative evaluation of accuracy and primary implant stability of implant placed using a conventional and dynamic system. It's a prospective study. So the aim of my study is to evaluate and compare the accuracy and primary stability of implant placement using dynamic navigation system versus conventional freehand techniques. So the objectives of my study was to evaluate apex deviation, which is how the implant apex or the tip moves from its initial ideal or its initial planned position. The platform deviation, wherein the platform deviation refers to switch in the location of the platform, which is the upper portion of the implant that connects the restoration from its surrounding bones from its ideal or initial planned position. The angular deviation, the angle between the implant before and after placement that deviates. This may have to do with the implant tilt with respect to the desired or optimal angle. So the secondary outcome is the implant stability, which is measured using resonance frequency analysis. So totally 10 cases or 10 implants will be placed using conventional technique, which is freehand, and the 10 implants will be placed using dynamic navigation system. And the inclusion criteria, the patient's age must be 18 to 60 years. The individual must be present with missing dentition, necessitating implant restoration, absence of soft or hard tissue defects, or any lesions that may hinder implant placement. And next is systemically healthy patients and participants voluntary to sign the informed consent. The exclusion criteria, mostly all the exclusion criteria which implant placement would be wouldn't be possible. And then on missing pre-operative or post-operative CB data were excluded from the study. So totally 10 cases were done. I would like to show 3 cases among them because of the time constraint. So the first patient is a 20-year-old male with a chief complaint of missing upper left and lower right region for the past 6 months. There's no relevant medical history, and the patient revealed a history of extraction 6 months back. So the general examination missing 4.6 and 2.6, some DCs were present in 4.7, 1.6 and 1.7, and the routine blood investigation, which is all normal. So the CBCT data showed the available bone height was around 15 millimeter, bone width was 8 millimeters. So the length of the implant which we decided to place was 10 mm and the diameter was 4.2 millimeter. So this is a conventional technique where we did a mid-crestal flap and opened the flap, and then osteotomy was prepared, and then implant was placed in 4/6. And then we did a resonance frequency analysis. The RFE value came up to 68 ISQ, and then sutures were placed, and the implant prosthesis was given after 4 months. So next is the case, the same patient where we did 2/6. The bone height was 10 millimeter, bone width was 6 millimeter. The length of the implant, which we selected, was 8 millimeter, and the diameter was 4.2 millimeter. This was placed using dynamic navigation system. So initially we had taken a CBCT, and then an intraoral scan was taken, and both were merged. And then the implant planning was done in relation to 2/6. This was the initial plan on the path of implant insertion. So this is the pre-operative view of 2/6. Incisions were placed and mid-crestal incision placed, and the flaps are open. So then we traced, calibration was done through the tracer tip. So we generally mark 3 landmarks around the neighboring tooth just for verification to calibrate the tips. And after initial calibration of the trips, and the drills were also calibrated, and then osteotomy was done. As you can see, dynamic navigation generally refers to a live implant placement. So you can see where the drill is going. So here the initial drill, we can see that it was all the parameters was within the range 0.2 mm and only 0.8 degrees of angular deviation, and we had to go 5.8 millimeter even deeper. And then osteotomy, the final osteotomy, so we almost reached close to 1 millimeter in the screenshot. And then the implant was placed. Then we did a resonance frequency analysis, and then we got an RFA value of 76 ISQ, and then sutures were placed in 2/6, and the prosthesis was given after 6 months. Is case 2, where a 46-year-old male with the missing lower left first molar, 3/6, and no medical history. And then we CBCT, we decided to do the bone height was around 10 millimeter, and the bone width was 7 millimeter. So implant size of 4.6 was planned. This is a pre-operative 3/6 mid-crestal incision, routine conventional procedure. Everything, flap was open, full thickness flap, and osteotomy is prepared. Implant was placed, and then we got an ISQ value after resonance frequency analysis of 69. Sutures were placed. This is case 3, 39-year-old female patient, missing right first molar, 4/6. For past 5 months, no relevant medical history, and the extraction was done 5 months back. All the blood parameters were normal, and then CBCT was taken. The available bone height was around 14 millimeters, and bone width was 6 millimeters. So the planned implant was 10 millimeters into 4.2 using dynamic navigation system. Again, CBCT was preoperative CBCT was done. Intraoral scanning was done, and then they were merged. Then implant planning was done in relation to 4/6, and the nerve tracing was also done. So this is the preoperative view. Again, full thickness flap and was elevated, and then the nerve canal was already traced. And this is the nerve canal tracing. We had like 4-5 millimeters. We were away from the nerve. And then each tip should be calibrated. So calibrating of the tip axis tips were done. And then the drills were also, the landmarks around the implant was also traced, and then the drills were calibrated. Then osteotomy was done. Each and every drill should be calibrated, including the implant, for accurate placement. So we can see around 0.1 mm only we have deviated, and angular deviation was only 0.9 millimeters, and we had 1 millimeter of depth to go. And then the implant was placed in relation to 4/6. Then we got an ISQ value of 80 after resonance frequency analysis, and then sutures were placed. And this is another case where we did 4/6. There was conventional. This is the initial case where we had to compare apex deviation, angular deviation, and platform deviation. So you can see their angular deviation was 2.3 mm. I mean, apex deviation was 2.3 mm from the initial plan side, angular deviation was around 7.2 millimeter, and the platform deviation was around 1.8 millimeter. And for dynamic navigation, the apex deviation was around 1.1 millimeter, angular deviation was 3.8, and platform deviation was 0.8. So these were the results of all the 10 cases, comparing the angular deviation, platform deviation, and then the apex deviation for both the techniques. And this was the resonance frequency analysis, the SQ value for conventional as well as dynamic navigation. So the statistics showed the conventional freehand technique, the apex deviation was around 2.52, and
good evening to the judges. First of all, I will start with the topic name, the assessment of tooth ridge angulation, sagittal root position, labial bone perforation, and labial bone thickness in maxillary and mandibular anterior tooth. It's an observational study using CVCT. Now, coming to the introduction, continuous innovation in the field of dental implantology has gradually changed the treatment options for replacing missing tooth and has changed the thought process for rehab of compromised cases with fixed dental prosthesis using artificial root analogs. With newer advances in the bone graft materials, tissue signaling molecules, use of navigation system, and precise prosthetic components have increased the predictability and long-term success of dental implants in single and multiple teeth replacement. To meet these objectives, concept of prosthetically driven implants plan has emerged. Immediate implant placement has become a common surgical protocol in clinical practice. This therapeutic concept was introduced by Schultz and Henke in 1976 as an alternative protocol to the classical delayed implant surgical protocol proposed by Brainmark. Now, the important points here, the root position. Root position of an implant is crucial for implant treatment planning in the anterior aesthetic region, especially in immediate implant therapy. Examining the teeth that need to be extracted and replaced by an implant is critical because the position of implant concerning its neighboring tooth and the anatomy of the ridges in all three axes have a long-term impact on the gingiva and the implant prosthetic aesthetics. The root position inside the alveolar housing have been used in studies to assess bone quality and to address implant placement problems or the requirement for adjunctive soft tissue or hard tissue augmentation during the treatment planning. Implant should be put in a prosthetically driven location in best case scenario. Immediate implants, placement of implants may cause surgical difficulties that may compromise the outcome or possibly be fatal. The anterior maxilla is said to be the weakest location of the implant placement from biomechanical standpoint, emphasizing the need for the prosthetically driven implant position and angulation in the alveolar arch. A clinical assessment and radiograph with CGCT are essential for precise information before implant placement when there is significant amount of alveolar bone alteration following tooth extraction. And unfavorable results that can be assessed and treated in advance with the aid of proper planning is the labial bone perforation, tooth ridge angulation, TRA, and root location angulations or SRB are two crucial factors that can be taken into account when planning the placement of dental implants. When the root position or TRA are unfavorable, it can lead to uncertain results in immediate implant placement with complications with bone perforation or in need of additional augmentation procedures. So the objectives here, we are going to find the LBP, labial bone perforation, in respect with the TRA, SRP. TRA means tooth ridge angulation, SRP is fat root position, and the labial bone thickness. Now coming to labial bone thickness, the labial bone thickness is the alveolar bone morphology in the maxillary and mandibular tooth area that helps in planning in post-extraction implant placement. The majority of bone remodeling occurs after dental extraction in the buccal plate with the vertical loss of 1 mm and larger degree of horizontal resorption. The thickness of buccal alveolar bone wall, especially the bundle bone, whose vascularization depends on the pudendal ligaments, undergoes extensive remodeling during the healing process of the alveolar bone. This influences the soft and hard tissue volume and its relationship with the implant, which impact the biological and the aesthetic results. The buccal bone should be at least 1 mm to prevent recession, and the bone thickness approaches to 1.8 to 2 millimeter. The bone loss decreases significantly, and some evidence of bone gain is also seen. The thickness of buccal bone crest not only significantly influences the horizontal gap fill, but also the vertical crest absorption. The position of teeth must be considered. Now, in this study, we have used in vivo study for the prospective observational study. We have reviewed the articles from Demerkan, Jarana, Mogadas, Khan et al., Ankit Medicari et al. The methodology is to present study will be include a sample of 130 patients, and the CBCT scan will be obtained for diagnostic, therapeutic, and other research objectives. Informed consents have been obtained from each patient. Material includes CBCT of images of fully after teeth of central, lateral, and canines with fully formed apices will be taken. These are some of the standard photographs we have taken. Exclusion criteria includes patient with systemic diseases, orthodontic treatment involving patient alveolar ridge augmentation, done patient supernumerary, missing or retained tooth, and pre-existing implants and alveolar bone destruction. Procedure plan for TRA, we have taken point A. Point A is done with the reference line along the long axis of the alveolar ridge. Will be measured by line bisecting the width of alveolar bone at crest and 3 to 5 mm apical to tooth apex. Second reference line B is drawn along the long axis of tooth with the reference as point B. The angle between the two lines was measured and is calculated as TRA. This is the standard photographs which we have taken. Now coming to SRP. SRP we have done with respect to Khan et al. Classification. It includes 4. Class 1 is a full root portion of anterior tooth in contact with labial cortical bone plate. Class 2, the apical third of the root portion is located in the middle of the alveolar housing, but not in contact with either the labial or lingual cortical plate. This is just photos. Now the LBP, the labial bone perforation. Root form implant for maxillary and mandibular teeth will be selected from an implant database provided in the virtual implant software to replace the examined tooth with suitable diameter. The diameter of implant selected was 3, 3.5, 3.75, and 4 for the anterior tooth from both the maxillary and the mandibular. The implant length will be determined with 3 to 4 mm implant apically anchored in native bone and 1 mm of subcrustal to a labial cortical plate in the alveolar housing, while avoiding contact with the lingual alveolar bone. When the virtual implant will make contact with or will extrude the outline of cortical bone, the LBP is considered to be occurring. Now the labial thickness of the labial bone thickness, it is calculated at 0.1, P1, P2, P3, and P4, which is 1 to 5 millimeter, and at the apex. The distance from the CEJ to the alveolar bone crest was also measured. This is the standard photographs. First, the CEJ to alveolar crest bone is measured, and then P1, P2, P3, and P4 is.
Okay. So these are the photographs of standard protocol followed.
Yeah. Go on.
Okay, these are the photographs of standard protocol followed. Extraction was done with utmost care. Socket width was measured, and implant was placed with standard immediate implant placement protocol, and bone graft was placed. And in group A, buccally advanced flap was sutured over the bone graft. In group B, PRF membrane was prepared and placed over the implant and sutures placed. Group C, connective tissue graft was procured from the patient's palate and placed over the implant and sutures placed. In clinical assessment, socket coverage after 3 months was assessed, mucosal thickness measured, and attached mucosal width was measured using a stent. Coming to results, in comparison of attached mucosal width among the 3 groups at baseline third month showed equal clinical significance, but no statistical significance. And in comparison of mucosal thickness among the 3 groups at baseline and third month, group B showed slight clinical advantage, but no statistical significant advantage. And coming to conclusion, the gain in the attached mucosa was found similar in all three techniques with slight better clinical outcome in group A. Mucosal thickness was again found to be almost same in all three groups with slight clinical advantage shown in group B. Factors like phenotype of tissue covering the implant and amount of attached mucosa supporting the implant area are very crucial in preventing peri-implantitis in relation to the implant. Thus, in the comparison of all three groups, invariably fail to exhibit any statistically significant difference among them, assessed through all three parameters. However, at large, all techniques showed equal success when assessed with similar parameters. Limitations of the study were small sample size, standardization of the sockets, and study variables like age, gender, amount of keratinized tissue, site of implant placement, phenotype of connective tissue graft, and make and design of the implant. Now, coming to the answer to the research question, difference among the various groups in the present study was found to be little or negligible. Hence, decision on selection of such a technique should be more of case and technique sensitive rather than review based, since they were all found to be equally efficient in achieving a complete closure of extraction socket. And clinical implication of research conclusion, the selection of the technique to meet the objective of complete closure of an extraction socket along with implant platform is left open to operator skill and operation site, and should consider least traumatic and most feasible technique among these three most commonly performed techniques, as each of these techniques are proven to be equally effective. These were my references. Thank you. Good evening, respected jury. The title of my paper presentation is Comparative Evaluation of Mucosal Phenotype and Extent of Coverage Achieved with Usage of Connective Tissue Graft, Platelet-Rich Fibrin Membrane, and Advanced Buccal Flap in Immediate Implant Procedure, a cohort study. The whole study was initiated upon a research question, that is, among the commonly practiced surgical procedures, which is the most effective in achieving complete mucosal coverage for implants following immediate implant procedure. Background of the study was immediate implants are placed in relation to extraction sites or sockets immediately following extractions. The main challenge for a surgeon during immediate implant placement is an adequate soft tissue coverage around the implants. Ideal surgical technique to attain complete socket coverage, gain in width of attached mucosa, and achieve a thick gingival phenotype is yet to be comprehended. So here arises a need for the study. Since all these techniques need surgical intervention, the right selection of the procedure would benefit the patient. So, a study focusing on intercomparison of these techniques need to be searched from the literature, or if not found, an original research work need to be undertaken. And limitations in the key articles reviewed were, none of the studies were done to compare the techniques used to cover surgical site in immediate implant placement. Studies have ignored to measure the gain in attached gingival zone, which is a major objective of doing such surgeries. And the phenotype of mucosa achieved following socket coverage procedures is of high value, but these studies have not focused on this factor, omission of which is found to be a major limitation. The rationale for the study is achieving a complete coverage of immediate implant and extraction socket is a clinical challenge. Though several surgical techniques have been put forth to achieve this, a comparative study to figure out the best predictable technique is lacking in literature. Thus, a study need to be designed with a rationale of comparing the major techniques for implant and socket coverage that also take into account the limitations of studies reviewed. Aim of the research was to compare the mucosal thickness, width of attached gingiva, and extent of coverage achieved with usage of connective tissue graft, PRF membrane, and buccally advanced flap, along with bone grafts in the closure of immediate implant site. As per the aim, the objectives were the following: to compare the thickness of mucosal phenotypes achieved in implant site following the usage of connective tissue graft, PRF membrane, and buccally advanced flap for covering the immediate implant site, to compare the extent of coverage achieved over implant site with these three techniques, and also to compare the gain in the zone of attached mucosa achieved with these three techniques in the implant sites. Materials and methods includes study design, a cohort study with a sample size of 7 in each group, and period of study was 1 year. Inclusion criteria includes patients voluntarily willing to participate in the study with age ranging from 18 to 55, systemically and physically healthy individuals, ideal immediate implant sites without any active periodontal disease or bony pathology, and patients fit to undergo connective tissue graft or PRF procurement. The methodology was summarized as a flow diagram. The sites that require immediate implant placement selected as per the inclusion and exclusion criteria and prepared for extraction and immediate implant placement following the standard planning procedure. Sites were randomly divided into 3 groups upon its technique. Group A was buccal advanced flap with bone graft, 7 samples. Group B was PRF membrane overlaying the bone graft, 7 samples. And Group C was connective tissue graft over the bone graft, 7 samples. Extraction done with every care prescribed for immediate implant placement protocol. The total attached mucosa between mucogingival junction of either sides of ridge was calculated and
Good evening, dear juries. The title of my presentation is Relevance of Available Bond Width on Implants Placed in Close Proximity to Adjacent Teeth in Limited Interdental Edentulous Span Areas. The study was initiated upon a research question. Will an excess of bone width in limited bone available interdental areas have any positive influence on the prognosis of placed implants? So we all know that the inadequacy in shape, position, width or height of the available bone are considered as a major consideration while placing an implant that may result in a compromised placement. And the most commonly encountered such anatomical factor is the loss of buccal bone, which might result in a sloped, uneven, knife-edge ridge resorption pattern that results in insufficient horizontal bone width and that may alter the ideal final implant position. As per the studies by Spray et al., minimum of 2 mm of buccal bone in the anterior region and minimum of 1 mm of buccal bone in the posterior region is needed to avoid peri-implant mucosal recession and bone loss. Thus, for selecting a right implant, the length and width of the available bone should be taken into consideration. While considering the studies, three-dimensional radiographic studies lacks a combined evaluation of both the inadequate edentulous span as well as width together. Here arises a definite need for the study. A long-term evaluation of cases which had implants placed at close proximity to tooth with sufficient buccolingual width as well as the same place with inadequate buccolingual width has to be evaluated separately to assess its success and failure rate. And the reason for the fate of such implants are to be evaluated, and this will enable the clinician to prescribe implants in areas with limited edentulous span but with an excess of buccolingual width. The rationale for the study was to prognosis of implants placed in sites with adequate bone width and minimal span of available bone and sites having lesser bone width with similar edentulous span. Aim of the study is to evaluate the influence of available bone width on the implants in limited interdental edentulous span areas. The aim was extended to following objectives: to assess the bone level changes radiographically using CBCT, to evaluate the implant survival rate after 6 to 12 months of loading, to assess the papilla morphology and inflammatory status around the implants. And the patients were selected according to the inclusion criteria. Only implants placed less than or equal to 2 mm from adjacent teeth were included, and implants must have completed 6 months to 1 year of functional loading. Patients who have above 18 years of age were only considered. And the selected sites must have an intact periodontium in the adjacent teeth, and in order to standardize, the implant size was diameter lesser than 3.75 mm were only considered. And in order to fulfill the objectives, a methodology was formulated with the study design of prospective cohort study with a study sample of 24 implants with less than or equal to 2 mm proximity to adjacent tooth. And the period of study was set to 6 months to 1 year, and the tools used for evaluation was CBCT, RVG, and clinical indices. And this is the flow diagram, 24 study sites, which was divided into Group A and Group B. In Group A, where the implants were placed 1.5 to 2 mm adjacent to the natural tooth, where in Group B, which is placed in 1 to 1.5 mm adjacent to natural tooth. Again, it is the groups are divided into A1 and A2 and B1 and B2. A1 were the A samples with buccal or lingual bone 1.5 to 2 mm. A2 were the buccal or lingual bone 1 to 1.5 mm. Like that, in B1, the B samples with buccal bone 1.5 to 2 mm and B2 were the buccal or lingual bone 1 to 1.5 mm. This is a pictorial representation of the groups. As we can see that group A1 having an ideal distance and ideal bone, whereas in group B2 where there is a reduced distance and reduced bone. All the measurements of samples were recorded and separated, and on the review, the patients were assessed implant survival rate according to the health scale for dental implants proposed by ICOI PISA Consensus Conference, and the bone level changes were and the bone level integrity was evaluated by CBCT, and the inflammatory status was assessed using Lowenz-Silness gingival index, and morphology of the interproximal papilla were assessed using GEM classification. And the intra and intergroup comparisons were performed using SPSS23 software. This is the methodology of A1, where the mobility is assessed, probing pocket depth, morphology of interproximal papilla, inflammatory status of interproximal papilla, and the radiographic bone level using the CBCT. These are the photographs of A2, these are B1 and the B2. So moving on to the result, while evaluating the success and survival rate, there was an 100% success for group A when compared to the group B, where there is a failure was noted, but there was no statistically significant association between the groups and success and survival rates. And when considering the mean bone loss at each site, there was no statistically significant difference in the mean circumferential bone loss between the groups, even though there was an increase in the bone loss in the group B, where there is placed in less than 1.5 mm to the adjacent natural tooth. And the morphology of interproximal papilla, there was no statistically significant difference. And while considering the inflammatory status, there was a slight inflammation increased in the group B, but there was no statistically significant difference between the groups. So we come into a conclusion that the implants placed at a standard distance, which is 1.5 to 2 mm, achieved 100% success, and those with a close proximity to tooth have a significantly lower success rate and showed an increased bone loss and inflammation. Thus, the study concludes that the distant to adjacent tooth is the critical factor, whether the buccal or lingual bone did not compensate for the negative effects of this close proximity. So there are some limitations for the study. First one is the study variables like age, gender, sample size, and the length of the implant. And also the sample size was calculated using the past similar studies. So a larger sample size would have substantiated the present study conclusions. And the preoperative level of the bone was standardized by using only the implants placing flushing with the bone level. Coming to the answer to such research question, the present study had several possible variables. So within these limits, the buccal or lingual bone, which was not seen influencing the prognosis of implants placed in close proximity to tooth. And the decisive factor in the success and survival of implants placed closer to the teeth were invariably the width of the bone present in this region rather than the buccal or lingual side. The clinical implication, the present study conclusion gives a fair confirmation of the established fact that a minimum bone availability of 1.5 to 2 mm between the implant and tooth is a necessity, and this requirement cannot be substituted with a more thicker bone on the buccal or lingual sides. These are the list of references. Thank you.